Okay, great. So this is going to be our first lecture in our 20 lecture series, going over everything that's high yield for step one. So let's go. So general reminders, general anatomy, very basics here. Reminding you that from the IVC, SVC, we have that deoxygenated blood that's returning to the right atrium. Okay, from that right atrium, we're going to pass through the tricuspid valve into the right ventricle. From the right ventricle, blood is going to be pumped via the pulmonary valve to the pulmonary artery. Pulmonary artery is going to bifurcate into two and send the blood to the lungs. In the lungs, something crazy, special happens. We're not really sure, but that blood ends up coming back via pulmonary veins. Now, for pulmonary veins, we have 4 pulmonary veins, 2 upper, 2 lower per side. Okay, and so we're going to have a total of 4 pulmonary veins. That's going to return our oxygenated blood to that left atrium. From there, blood is going to pass through the mitral valve into the ventricle. From the ventricle, it will be pumped out the aortic valve into the aorta and to the rest of the body. Okay, very basics, just sort of a general reminder of what the blood flow looks like. Okay, now when I'm looking at this aorta, what I see is 3 branches coming off of it. What are those 3 branches? If you could remind me, I have just plumb forgot. These ones over here. Good? Yes? That's okay. That's okay. So you're absolutely right. The leftmost one, where my pointer is now, is pointing to the subclavian. Okay. The way that you remember this is that for the right, there's 1 branch, and for the left, we have 2 branches. Okay. So on the right, we have our brachiocephalic. The brachiocephalic is going to continue to progress, towards our head, and then it's going to bifurcate into a right subclavian and a right carotid. Okay. On the left, however, we have our common carotid as a direct branch of the aorta, and our left subclavian, again, also a direct branch of the aorta. Okay. Great. Okay. So let's go to the next slide here. Going through our valves, we have our AV valve, our atrioventricular valves. That's composed of our tricuspid on the right and our mitral on the left. Semilunar valves are the pulmonary valve between the right ventricle and pulmonary artery, and our aortic valve. Okay, all information that we're comfortable with. One thing that I want you to start thinking about now that I'm really going to harp on this lecture is look at the direction that the valves go. If you look at, for example, this pulmonary valve, you can see that it sort of curves upwards towards the pulmonary artery supply rather than towards the right ventricle. Okay? It's almost like a cup that can catch any blood that's moving downwards. Okay? Look at the AV valve, the aortic valve here on the left side of the heart. You can see it's the same thing. It's almost cupped. It can catch any blood that's coming back towards the left ventricle. And that's good, right? Because we don't want blood regurgitating backwards. The whole goal of these valves is to prevent flow of blood in one direction. Okay? And so as we start talking about regurgitation, keep this shape of the valves in mind, that these valves are really preventing blood from going in a certain direction. And so if they become weaker, then that's what we expect to see. Okay, so in terms of the pressure that's being built up during the cardiac cycle, really that pressure is developing from that contracting heart muscle during systole. It's squeezing the blood and causing that buildup of pressure. As that pressure gets built up, the pressure is going to start to exceed pressure on the other side of the valve. Okay? When pressure inside of a ventricle exceeds the pressure on the other side of the valve, blood is going to start to move out of that valve. So when you talk about the aorta, for example, the aorta is always going to have some pressure in it. As the diastole occurs and your ventricle is relaxing, the pressure stays high within the aorta because of those valves, right? The valves are catching the blood and ensuring that the pressure doesn't decrease. So now when systole begins, the pressure inside of the ventricle has to overcome that pressure that's already in the aorta. Otherwise, blood is not going to go anywhere, right? So the pressure starts to build. Once the pressure in the ventricle overcomes the pressure within the aorta, that valve can open and allow blood to move out of the ventricle and into the aorta. Okay, and that is how the cardiac cycle works, essentially. Okay, great. So here, talking a little bit about potential energies, not really too worried about that. Just sort of a general rule. Blood is always going to move through circulation because of pressure differences between the entry and exit points, okay? And so the biggest energy differences, and this is something that they ask about to try and trick you. So where is the pressure highest and where is the pressure lowest? On the systemic side, the pressure is going to be highest in the aorta and lowest in the right atrium, okay? Think about it. It's going to be highest as blood is leaving the left side of the heart. That blood is going to go through the arteries, through the arterioles, through the capillaries, through the venules, through the veins, through the inferior vena cava, and eventually get back to the right atrium, and that is going to be the lowest pressure, okay? If you're ever asked about what is the pressure in the right atrium, it's typically anywhere from 0 to 5, okay? Very, very low. The pressure in the right atrium is always very, very low, okay? On the left side, it's obviously going to be a lot higher because you have blood coming back from the lungs. You have the left ventricle on the other side really generating a lot of pressure. So on the left atrium, that pressure is going to be a little bit higher. So typically the pressure in the left atrium is anywhere from 15 to 35. Okay? And so obviously the pressure in the pulmonary artery should be a little bit higher than that. Okay? Great. Okay. So again, left ventricle is a pump. Essentially, it's just turning that ATP energy into mechanical energy, generating blood pressure. Aorta's got the highest pressure. Veins is low. And the right atrium pressure, again, very low. Anywhere from 0 to 5 is acceptable for what that pressure is. Okay, and so we kind of talked about how all of this is occurring, where we have the very highest pressure in the left ventricle and the lowest in the right atrium. One thing to keep in mind here is that the veins are really going to be our body's way of controlling where blood comes and goes in terms of the heart. Veins are expandable. And so veins, because they have this ability to expand, can actually keep a lot of the blood in our system. If the veins are allowed to expand, our blood pressure is actually going to go down because we're going to have less blood going back to the heart. If we maybe give some sort of drug to contract those veins are now going to shoot that blood back up to the heart and increase our blood pressure, increase our stroke volume. And so, when you think about patients who, when they get out of bed, all of a sudden they get dizzy, right? We understand that, okay, this is just because they have low blood pressure. We totally understand that phenomenon. We're okay with it. But for step one, we need to understand the physiology behind it. These veins have very weak walls. They're not sturdy, muscular walls. They're very weak walls. When your patient stands up, now the gravity of all of the blood in their entire body is being pressed downwards into the veins of their lower legs. Okay? And so you can imagine having, the weight of 100 people standing on your shoulders is probably a lot more than just one person standing on your shoulders. Okay? And so now with all of that pressure of all of the blood here in the body, it's going to cause those veins to expand and reduce the amount of blood that's going north up to the heart. Okay? Great. And so, again, when a person stands up, we have more effect on veins than arteries. Another thing that they can ask you about on step one is where is this phenomenon occurring? And obviously we know that it's because of those expandable veins that we have that big problem when people stand up. Okay. Another important concept is this idea of laminar flow. In our arteries, what we see is that blood velocity is going to be faster at the center of our arteries, slower at the periphery of the blood vessels. Okay, and so if we were to look at a normal vessel, what we would see is that we have blood moving the fastest in the middle of the vessel, blood moving slower on the sides, and so this is just the idea of laminar flow. What's nice about laminar flow, it doesn't make much noise. Now, if we were to put our stethoscope on the aortic post, right, and we listened and we heard a systolic murmur, we would say, okay, I think that this is aortic stenosis. I know it because I memorized that systolic murmurs at the aortic post are always aortic stenosis. Okay, yeah, you could say that, but that's not going to take you too far. You need to understand that now that we have a stenosis of that valve, blood is not moving in this beautiful laminar way, right? Now blood is having to move through a much smaller area. So it's not going to be silent. It's not going to be laminar, meaning layers. It's going to be very turbid flow of blood. So whenever you have turbid flow of blood, blood that is not moving smoothly from one place to the next, that's going to make noise, okay? That's going to make noise. And so when you have murmurs, whether it's your, your S3 sound, or your S4 sound, all of these different murmurs that we talk about, they're all basically due to the fact that blood is not moving in a very organized and concise way. Okay. All right. So noisy flow, there's this old rule in physics, V equals Q over A. You don't need to know that for step one by any means, but just to kind of give you some context here. Narrowing or constriction can increase velocity, causing turbulence downstream of the constriction, like we mentioned on the last slide. And so stenosis is the classic one that we talk about. Okay, and just sort of the law behind some of these things that we hear. Again, not an equation that you need to know for step one. Just if you wanted a refresher on the physics behind it. I don't know why you would, but I left it in here just in case you're somebody that loves math. Never again, right? Yeah, no thank you. Yeah, great. So these are just some cases of where we can hear non-laminar flow. So we already talked about aortic stenosis. In aortic stenosis, what we have is a decrease in the diameter of the area that blood can flow, right? It's through less of a diameter, so it's going to make some noise. That is going to increase the mean velocity. Decreasing the diameter increases the velocity, and that is going to increase the amount of noise. Great, that's one. Number two, think about times when in the human body we have more flow altogether. If you have more flow, that is going to make more noise. So think about in late pregnancy, a woman who has 1.5 times her normal blood volume, right? Pregnant women end up getting a lot of blood, extra blood volume. It's physiologic. It's totally normal. It's what she needs to support that growing baby, but it can have effects that are appreciable on physical exam. And so, a pregnant woman may have a pronounced murmur in her heart because of all this extra flow and a turbulent flow. Other things you can see in pregnancy is an anemia, right? Because while she is still making hemoglobin, she's also making a lot extra volume, right? There's extra plasma in her supply. And so she gets this sort of asymptomatic anemia you can see, all right? So in late pregnancy, hearing a murmur in late pregnancy is not something that you need to be super alarmed about. If this woman gives birth and then after birth she's still having murmurs, okay, now we may want to get an echocardiogram, take an ultrasound probe, put it to the chest, and see what we can see there. But otherwise, it's pretty normal. Okay, hyperthyroidism increases the amount of flow, increases your stroke volume, increases your heart rate. A leaking valve or regurgitation is going to increase the amount of flow because now during diastole, when you're supposed to have one valve closed, one valve open, both valves are open. Okay, so now the heart is going to have to work twice as hard because it's pumping blood. If say this is an aortic regurgitation, every time during diastole, we have blood coming back from the aorta. We also have blood coming from the left atrium through the mitral valve. Okay, so we're having two sources of blood coming back into this ventricle, getting overloaded, and it's having to pump twice as much blood out of the ventricle. And so in that case, obviously, it's going to have an increased flow. Okay. Increased viscosity or decreased viscosity, excuse me. So in cases of anemia, when we have less proteins and less red blood cells in the bloodstream, that can result in a systolic murmur, low red blood cell count, which is basically anemia. Okay. Yep. So any increase in Reynolds number, which is this number here, can possibly cause turbulence. Okay. So changing any one of these factors can cause a increase in turbulence and more noise essentially during your cardiac cycle. Okay. So we have a 80-year-old patient who's presenting with a murmur for several years, symptoms over the last 6 months, and we do an X-ray and we see an enlarged heart plus a murmur. What are some of the things that we're thinking about? What's the first thing that pops up in your mind? For, just this history, someone who's a little bit older, who's been having this murmur for several years, but the symptoms are getting worse over 6 months, and then you do a chest X-ray, you see an enlarged heart. Yeah, excellent. Yeah, very good. So anything that is causing higher pressure, right? Anything that's causing that heart muscle to have to work harder. Heart muscle works harder, it's going to make the heart bigger, right? It's just like going to the gym and pumping a bunch of picking things up and putting them down. Your muscles are going to get bigger. The heart is the same way. So just like you said, atherosclerosis is 100% correct. If you have blockage of your arteries on a wide scale, pressure is going to increase in your systemic supply. That left side of the heart is going to become hypertrophied. Okay. Now, for an 80-year-old person, I would be willing to bet that every single 80-year-old person that you meet, you could, put a echocardiogram, take a little ultrasound, put it to their chest, and see a little bit of aortic stenosis. We all get calcium on our valves, right? Our heart is beating 60, 70, 80 times per minute. That means that valve is opening and closing that many times per minute. How many minutes are in a day? I have no idea, but there's a lot. And how many days in an 80-year-old person's lifetime? Quite a bit, right? And so every single person who reaches this age is going to have a little bit of calcium on their valves. How much calcium is going to determine how much aortic stenosis. And it just happens to be some people have more than others. Okay, some people are not lucky. And so this 80-year-old person that we see, we can guarantee that they probably have some aortic stenosis. We need to diagnose it first, but we can be confident that there's at least a little bit there. So in this case, we have growth of the heart muscle because it's trying to pump through that tiny little valve. Okay, just like you said, it's almost like a blockage. The heart has to pump a lot harder. This is called concentric hypertrophy. When we meet on Wednesday, we're going to talk about different types of hypertrophy. I think the cardiac pathology lecture is really a great lecture for you. And so we're really going to talk about some great stuff on Wednesday. All right. So with this same guy, with this 80-year-old guy, we put our stethoscope to his chest wall and we start hearing crackles. We're listening to his lungs and we hear crackles. Okay, so Natalia, can you tell me what would be causing crackles? Why are we hearing crackles? Yeah, exactly. No, you're 100% right. So, what's happening here is, if I can draw, whoa, what just happened? Sorry about that. Okay, so if I can draw here, here is our left ventricle. Okay, it's black for some reason. And here is our stenotic valve. Blood is trying to get through the stenotic valve. It cannot. Okay, so now we're going to have blood that's backing up inside of that left ventricle. Okay, it's getting very full, very dilated. Okay, that's why it looks like a big circle, I guess. Okay, so now at our left atrium, what we're going to see is that we're having blood backed up at the left atrium. Okay, now the left atrium is getting dilated, et cetera, et cetera. Now going into the pulmonary veins, blood's getting backed up there. So if blood is getting backed up with the pulmonary veins, that means at the alveoli, at that cellular level, we're having blood backed up there. It's getting congested. Whenever you have these vessels that get congested, we have something called Starling's formula, where you have the hydrostatic pressure, the oncotic pressure, all those different pressures working together. What's going to happen is fluid is going to move over the wall. Okay, the hydrostatic pressure is increasing in the capillary, meaning fluid's going to start to move over that wall. It's going to get into the alveoli, and we end up with something called pulmonary edema. All that pulmonary edema means is fluid within the alveoli. Okay? So, great. Most common cause of pulmonary edema is an increase in hydrostatic pressure due to left-sided heart failure. And that is what's happening to this gentleman as his heart is getting larger. We know that it's having a hard time pumping blood out of it. And so blood is starting to get backed up. It's going to get backed up at that left atrium, like we said, pulmonary veins, at the lungs, eventually the pulmonary artery, eventually the right ventricle, eventually the right atrium. Okay? In fact, the most common cause of right heart failure is what? Left heart failure. Yeah, you know that. I know you knew that one. The most common cause of right-sided heart failure is left-sided heart failure, right? We're getting blood that backs up and up and up and up and up until it affects that other side of the heart, okay? So whenever you are doing one of these questions and they tell you that you hear crackles, I always want you to associate that with pulmonary edema. Okay, and we're going to do a pulmonary lecture as well, and we're going to talk about different sounds that you can hear. And I remember when I was studying for step 1, I kind of thought it was all the same thing. Okay, crackles, wheezes, rails, it's all lung stuff, right? It's all like the same thing. But no, these words, the test writers use these words to kind of give you a clue into what's going on, okay? So crackles you'd be more likely to hear in a patient with pulmonary edema. You wouldn't hear crackles in a patient who has a pneumothorax, right? These things have meaning, and having those connections are going to give you a clue into the right answer. All right, so crackles equals pulmonary edema. Great. Anything else we can say here? I think it all makes sense. Any questions on this? No. Great. Okay. So aortic stenosis, again, we kind of talked about what aortic stenosis is. Essentially, we just sort of have a narrowing of that valve. Blood has a lot harder time getting through. You have an increased resistance and an increased pressure in that left ventricle, okay? And so our most common cause is going to be calcification due to aging. Another cause that you can hear is maybe some endocarditis. After chronic endocarditis, not an acute, but chronic endocarditis. And so that's for our aortic valvular stenosis. Okay. Velocity of flow and circulation. This is actually surprisingly, I know I've gone over some low yield stuff today so far, and I'm sorry about that, but this does not qualify as low yield. This is very important idea. You will get a question on this. Okay, I'm going to put 2 stars because I'm really confident that you will get a question on this concept I'm about to go over. So the velocity of flow in circulation. So before we go into the text here, I just want to take a quick look at the diagram. So whenever we see a diagram, first thing we do, we look at the axes. It looks like on my x-axis, what I have is a location where we're going from the left atrium and left ventricle all the way back to the left atrium and left ventricle. So we're just moving all the way through the supply. On the y-axis, we have velocity on this bottom diagram and cross-sectional area, the total cross-sectional area on the y-axis for this number 2 diagram. Okay, so great. So let's look at this first one. That's number 2. And what we see here is that at the left atrium and left ventricle, the cross-sectional area is not very much. It starts at 4 centimeters squared. When we reach the arterioles, however, going into the capillaries, this is going to be the highest cross-sectional area on the systemic side. The highest cross-sectional area on the systemic side is at the capillaries. And that makes sense, right? Because we have billions of capillaries. And so if you added up all those capillaries together, you'd probably have a few football fields, right? It's really just multiplication to domination here. We have more things. As blood is returning to the heart, we go from having billions of areas for blood to flow to just being one giant IVC. And so obviously the cross-sectional area is going to drop. Blood's going to enter the heart, and then it's going to go into the lungs. And then in the lungs, you can see we have the highest overall cross-sectional area in the entire body. Okay, and so the lungs, even though they don't really take up that much space relatively, there are so many capillaries in the walls of those alveoli in our lungs that if you add them all together, the cross-sectional area is going to be the greatest in our entire body. Okay, quite large. And so that's our cross-sectional area diagram. Now, if you think about, some of those rules of physics and thinking about what happens when you have a highway compared to what happens when you have small little side streets. When you have a highway, people can drive pretty fast. They're going in, pretty straight along the highway, unless you live in New York. You have a little bit of turns. I don't know how it is in Atlanta, but for most highways, it's very straight. You can drive very fast. Okay, and so when we think about the human body, it's the same thing. When it's just one vessel, it's going to be able to travel much more quickly. Okay, as we increase the cross-sectional area, blood is going to really slow down to a crawl, just like when we take that exit off the highway and take the side streets, it goes a lot slower. And then we see the same thing on the venous side. No surprise there. Okay, so now that we kind of understand these diagrams, let's go to the text. Velocity of flow, cross-sectional area are inversely related. If you memorize that statement, you will not miss a question on this idea. Okay, but we're going to go on anyway. The arterioles are the site of greatest resistance to blood flow. If you do UWorld questions, this is going to be one of your questions, because this fact by itself, for whatever reason, they love asking about this fact. Memorize this. The greatest resistance to blood flow is at the arterioles. And if you think about it logically, you may want to say capillaries because they're the smallest, but it's actually the arterioles. And the reason is arterioles have muscle in the wall, capillaries do not. And so that muscle is going to give an extra little oomph to the amount of resistance that arterioles can provide. Okay? Yep. So these are going to control our blood flow. And yeah, great. Any questions on this? No? Great. Okay, so now we get to start the fun part of talking about our cardiac cycle. And so you can see that we have a little diagram here. Before we get into the diagram, we're going to look at our axes. On the x-axis, we have our time in seconds. On the y, we have pressure in this top diagram and ventricular volume on the bottom diagram. And on the diagram, we have a few different lines, a few different numbers. Each of these numbers is going to be indicating a different event happening in the heart. Okay, and so we can see that starting with our number 1, what we see is that we have a brief increase in pressure. And this is in the left ventricle, I should add, that this whole thing is taking place in the left ventricle. So in the left ventricle, we have a little bit of bump of pressure increase. Okay, so what does that represent? Why during diastole would we have an increase in pressure in the left ventricle? Absolutely, no problem. So at this number 1, you can see that there is a brief increase in the pressure. You see this little increase, a bump like this? Yeah, so what is responsible for that, right? This is during diastole. The ventricular muscle hasn't started contracting yet. Why do we have that little increase in pressure? You're allowed to look over here, by the way. Cheating is encouraged in this class. Yes. So at this point, the mitral valve is open, and we're at the end of diastole. So what's happening is the left atrium is doing the atrial kick. Okay, so at the end of diastole, normally diastole is very relaxed. All you have is blood flowing through that mitral valve into the left ventricle very passively. However, right at the end of diastole, you have this atrial systole, this atrial kick, our P wave, right? That's what P wave is atrial systole. So this atrial kick is just going to give a last little boost of blood. Whatever blood is left over in the atrium, we just want to dump all of that into the ventricle. Okay, so this first little bump that we see is going to be our atrial systole. Great. Now, what we see next is our pressure rapidly starts to increase. Okay. And so this rapid increase in pressure is going to be our ventricular contraction. Okay. At this point, the mitral valve has closed and the aortic valve is still closed. So what we have is a ventricle that is increasing the pressure and just pushing against both of those valves. Okay. Now we talked earlier about the shape of the valves. Okay. So this is my left ventricle. Okay. Kind of shaped like this. Great. This is our mitral valve, kind of shaped like this. And then this is our, aortic valve. Okay. Shaped a bit like this. Now inside of this left ventricle, we have blood that is inside of it, and the pressure is increasing. Blood is trying to push out of this valve, which is our mitral valve. Blood is trying to push out of this way. Eventually, once that pressure reaches the pressure that is within the aorta, the blood is going to be able to exit out of that left ventricle and exit out of that valve. Okay? But first, we have to get to this point right here at number 4, where you see that pressure has overcome the pressure in the aorta. Okay, and so this dotted line that you see is that aortic pressure. Once these two lines meet, you can see that they start to move together. Why? Because the pressure that's being generated by the left ventricle is greater than whatever pressure is generated just by the aorta itself. Okay, so these two are going to travel together until number 6. So what happens at number 6? Why do we see these two lines start to go in different directions? At number 6. The valve closes, right? Good, excellent. So the aortic valve has closed at this point, and you can see that the left ventricle continues to relax. Okay, it's going to continue to relax. This is the beginning of diastole, while the aortic pressure stays high. Okay, and so seeing that this line, it is trending down a little bit, but it's still staying pretty strong, right? The lowest that it gets is 80, which is a good diastolic pressure, right? If instead we saw this dotted line, and if instead of having this nice curve like this, if instead we saw a drop like this, what might we think is happening? This is a little bit of a tough question, okay? So if the aortic pressure, instead of staying high, right, stopping basically at 80, if instead during diastole we saw the pressure in the aorta dropping very quickly, what might we suspect is happening? Yes, Natalia, I'm so proud. Yes, really, we're going to have fun in this class because you have a good amount of knowledge. I wasn't sure if you're going to get that. So, yes, you're absolutely right. In regurgitation, what happens is blood doesn't stay within that aorta. Blood starts coming back into the left ventricle, and so that aortic pressure does not stay high. Excellent. At point number 8 here, what we see is the mitral valve now opens, and it's going to start dumping blood into the left ventricle. Okay? Great. And then if you look here in our bottom diagram, you can see what's happening to ventricular volume, and it's kind of inverse of what's happening to ventricular pressure. Okay, and so you can see during systole here, the ventricular volume rapidly decreases, which is what you would expect to happen during systole, right? All the blood within the left ventricle is being pumped out of that left ventricle, so the volume should be going down, right? That makes sense. And then during diastole, what we see is right here after point number 8, the pressure, I'm sorry, not the pressure, but the volume starts to increase within that left ventricle. And so that is what happens there. Okay. All right. Any questions on this stuff? No, excellent. Yeah, no problem. No problem. Good. If you have any questions, please never feel afraid to stop me. I don't think that you would, but if you did, don't. Okay. And so here we can diagram everything we saw in that last slide, along with our beautiful, we have our ECG here. Okay. We have our heart sounds. Okay. So here's our S1 sound. That happens to be corresponding to the closure of the mitral valve and the tricuspid valve. Our S1 is corresponding to the mitral valve and tricuspid valve. Those valves that are between the atria and the ventricles are closing. That's our S1, right? S2 is the valves that are our pulmonic valve and they are our aortic valve. The valves that are between the ventricles and wherever they're pumping the blood are closing during our S2, okay? And that's something we're comfortable with. Now, going back to our ECG very quickly, I just want to review. Here is a P wave. This is a really ugly ECG. I hate it. But you can see here's a P wave base almost there. So that P wave is going to correspond to that atrial kick. That's our atrial systole. Our QRS complex corresponds to ventricular systole. Okay, ventricular contraction goes along with our QRS complex. And our T wave, which you can barely even see here, our T wave is going to be ventricular relaxation or repolarization. Okay, great. And on the bottom here, you can kind of follow the pressures in the right ventricle, pulmonary artery, right atrium. In my experience, you don't get many questions on right side of the heart type stuff. I don't know what your experience has been, but really they tend to just ask about left-sided heart stuff. The one thing that they do ask you about is the one thing that I already reviewed with you, which is what is the pressure in the right atrium? And we said that it's usually anywhere from 0 to 5. Okay, very low. Okay, great. So our atrial systole, we mentioned before, this is our atrial kick. It's the P wave on our QRS complex. If we have a problem in our heart, we will hear an S4 corresponding to that atrial systole. Okay, and what is an S4? Well, S4 is a sound that you hear in patients that have a very stiff heart. Okay, think about your patient that we were talking about earlier with arterial sclerosis. Okay, that patient has probably been developing hypertension of their heart for quite a long time. As they have hypertension, the walls of the heart are going to hypertrophy. They're going to get thicker. When you have those thick walls, they get stiff. So what happens when you try and do your atrial kick into a ventricle that has stiff walls? It's hard. Exactly. Yeah, it's very hard. Those walls are not going to take the blow very easily. They're going to be very stiff. It's almost like trying to throw a water balloon against a concrete wall, right? It's going to kind of smack. And so our S4, which is the sound that comes before S1, is the sound of a stiff wall in your heart. Whenever you hear them talk about S4, or if you ever hear an S4, in your mind, I want you to imagine that this patient has ventricular walls that look like concrete walls, okay? Very stiff, hypertrophied walls. That's what an S4 is. Nothing fancy, nothing complicated about it, okay? This is just a patient who's had hypertension for a long time and has now developed stiff walls of their heart. We're going to talk about S3s too, and S3 is very different. It's going to be a different kind of patient. So this is how you're going to memorize this. S4 is a patient with hypertension. Okay, so pathological vibration of ventricular wall during atrial contraction. Great. Valves. Some valves are open, some valves are closed. We know this stuff. This is very basic stuff. Okay. Next, we have our isovolumetric contraction. What does this mean? So you remember there was a point on that diagram where we had our mitral valve closed and we had the aortic valve closed. The pressure was building within the ventricle until that pressure became greater than the pressure within the aorta. So for all that time that the ventricle is contracting against two closed valves, if you look at this diagram, what you see is two valves that are closed. We have our mitral valve closed and we have our aortic valve closed. that is going to be your isovolumetric contraction. The volume within your ventricle is not changing, although you are contracting the ventricle. Okay. On our EKG, this is our QRS complex as the ventricle starts to contract. And this is going to be where you hear that first heart sound, which is the sound of that mitral valve closing and the tricuspid valve closing. Okay. Excellent. And so next we have phases of ejection. The first part of ejection is as you can imagine, doing, I always compare these things to working out in the gym. I'm, not an especially smart person. So, these very basic, comparisons work for me. So if you say you're picking up a weight and you're doing a curl, right? A muscle curl to work your bicep here. As you first start to pick up that weight, that's when you're going to have the most force, right? You're going to grab that weight, you're going to start building up the force, and eventually, that first part's going to be the rapid part. And so same thing with our heart. As the heart is trying to pump that blood out, the initial part is going to be the fastest. It's going to have the most force. The blood's going to be leaving rapidly. Now, as we're getting to the top of the curl, the top of the rep, now the force is going to be less and less and less as we get towards the end. Same thing here for the heart. It's still ejecting blood, but it's going to do it a little bit more slowly. Okay, great. This is all ejection, but technically there's phases. Not super important, but I guess it's good to know. All right. Now, as the aortic valve, pulmonic valve close, we get our second heart sound. Right. S2 is the sound of pulmonic and aortic valves closing. We know that. Now all four valves are closed for this phase, so it's isovolumetric. Okay. And this is just sort of the first part of diastole. All right. And then in 6, so the last few phases, we have early rapid filling. During early rapid filling, what's happening is the mitral valve opens, right? So the heart was relaxing, the ventricle was relaxing, and now the mitral valve opens. It's going to start allowing blood to come into the ventricle. Now, what happens when we have a patient that has, instead of having this big stiff heart, what if they have a big floppy heart? What if they have a heart that has a very big dilated ventricle that during diastole doesn't really pump that much blood out? Okay, so we have this big dilated ventricle. It's at the end of systole, there's still blood in there. Now diastole starts. We open that mitral valve. Okay, imagine taking a cup of water and then dumping that into a full bathtub. That's going to make some noise, right? That's what's happening here. So during the first part of diastole, early diastole, if you hear a sound there, that's the sound of that mitral valve opening and blood going into an area where there's already a bunch of blood. It's all sloshing around together. Essentially, you have an overfilled ventricle, okay? And so this type of patient is going to be a CHF patient, okay? I can't write CHF apparently, but CHF patients are patients that have volume overload, okay? And so S3, this is the sound that comes after S2. This indicates that your patient has overfilled ventricles, congestive heart failure, dilated cardiomyopathy. Any of these conditions that decrease the amount of your ejection fraction can result in an S3. Okay? And that's a very different patient than that patient who had the S4, who has hypertension and a really, hypertrophied big muscle heart, right? And stiff ventricles. And so, in answering these questions, you are going to be able to use all of this information, all of these little factoids, all these little weird ways of thinking about things in order to sort of narrow down your options. If you're told in a question stem that your patient has hypertension, look for something like an S3 in the answer choices. Maybe it's there. And look for an S4 in the answer choices. Don't look for an S3, okay? Great. And then late slow filling, and that brings us back to the beginning of systole. All right, great. And so this is sort of just reviewing the same stuff that we've talked about before. When do the valves close? And I think we're pretty comfortable on that now. Our S1, we said before, is the sound of our mitral and tricuspid valve closing. Our S2 is the sound of our aortic valve closing, as well as our pulmonic valve. Now, our S2 is, we have to talk about S2, right? We have to talk about this really silly thing called physiologic split. Okay, so whenever we talked S1 and S2, I always told you all of the valves that were closing, right? It's not just valves on the left side, but also valves on the right side that contribute to the heart sounds. Every time we hear that lub-dub, 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 each lub is 2 valves. Each dub is 2 valves, okay? And so for the lub, for the S1, we don't really talk about breaking that into 2 different sounds, right? Lub is just always lub for whatever reason. Our dub is dependent on how much blood is coming back to the heart. I'm going to say that again. Our S2 is dependent on how much blood is coming back to the heart, okay? And so when you take an inspiration, right? When we inspire, what's happening is we're dropping the pressure in our thoracic cavity, right? In order to breathe, take a deep breath in, what we do is we drop the pressure in our thoracic cavity. We're basically making a vacuum and we suck air in, right? Now, when we decrease the pressure in our thoracic cavity, that's actually going to allow more blood to be inside of our thoracic cavity as well. Okay? So when you take a deep breath in, you're going to have less blood going to the left side of the heart. As we breathe in, most of that blood that was supposed to go to the left side of the heart just kind of hangs out in the lungs. It doesn't go to the left atrium as it's supposed to. We're taking that deep breath in, so the pressure there is pretty accommodating to staying in the lungs rather than returning to the heart. Okay, so when we take in that breath, we have less blood returning to the left side of the heart. So when the heart starts to pump, less blood, that valve is going to close a lot quicker. It requires less time to pump that blood out. And so what we end up seeing is that our aortic valve is going to close earlier than the pulmonic valve. Why is that? Again, I'm going to explain it one more time. When we take a deep breath in, the blood stays in the lungs. It stays in those alveolar capillaries rather than returning to the left side of the heart. Because the left side of the heart now has less blood to pump, it requires a lot less time. So that valve, the sound of the AV valve closing is going to happen a lot earlier than otherwise. Okay. Does that explanation make sense? Basically. Okay. So that is the reason for our S2 split. When we take a deep breath, we have more capacitance, more ability for our lungs to hold on to that blood. Now the left side of the heart, okay, I'm just explaining it again. But yeah, so that's essentially what we expect to see. On inspiration, we have our S2 gets split into the aortic component and pulmonic component. On expiration, they sandwich back together. Okay? All right, great. And so here is the mechanism that I just described. Described again, decreased thoracic pressure, increased pulmonary impedance, increased capacitance, more blood is going to stay in the lungs, and that is going to increase the venous return as well, increase the stroke volume, increase the P2 closure time, and then also simultaneously we have decreased left ventricle filling, giving us decreased stroke volume, and that blood is going to leave the heart a lot quicker, giving you a decreased A2 closure time. Ultimately, the result is a split of that S2 sound. Okay? All right. So I feel like I've explained that every way possible. We can kind of move on to... right? Okay, we can move on to the next thing. So if there's something we learn in, for step 1, the only reason we learn it is to learn what can happen when it goes wrong, right? And so the first thing that can happen is our fixed split of S2. It's going to be an S2 split that's unaffected by inspiration. Whether we're inspiring or we're expiring, we are hearing both components of that S2. Okay, so why would this be happening? Well, essentially, what's going on is we have this delayed closure of the pulmonic valve because the right ventricle has more output than the left ventricle. This is the same reason that we have an S2 split in the first place. We said that when the left side of the heart has less blood to pump, it's going to close a lot quicker than the right side of the heart, right? That valve is going to close a lot quicker than on the right side of the heart. So now when we have a fixed split, it's the same thing. It's just happening all the time. So let's think about this. What kind of condition would cause the right side of the heart to have more blood to pump than the left side of the heart? How could that be? You know, blood comes to the right side of the heart, it goes to the lungs, it comes back to the left. How could there be less blood to pump on the left side of the heart? How could that be? Cheating is always encouraged in this class, okay? Okay. All right, so since you told me you cheated, you shouldn't have told me that. Please help me understand how. Why does atrial septal defect mean that we have this fixed split? So we have this hole in our heart, right, between the left atrium and the right atrium. Where does blood go? Does it start going from the left to the right, or does blood come from the right and move to the left? Left to the right, right. And this makes sense because we talked about before, what is the pressure in the right atrium? 0 to 5, right? So whatever it is on the left side, it's going to be higher than that. And so we're going to have blood moving over. So now we had blood that was in the right side of the heart. It went to the lungs. It came back. Some of the blood went into the left ventricle. Some of it went back to the right side of the heart. So relatively, the left has less blood to pump than the right. So the left is going to be able to pump way quicker, right? If these are the two sides of the heart, right? The left is going to be able to just pump way quicker and be closed way before the right side of the heart, okay? Because it has less blood to pump. It has less work to do. It's going to get that work done quick. And so that is going to be not going to be affected by inspiration or expiration. It's just you're always going to have this split of S2, okay? All right, so whenever you hear fixed split, I want you to think about atrial septal defect. I did not mean to black that out, but atrial septal defect is going to be the number one thing that you're going to see on your step 1 for this fixed split. Right heart failure can do it too, but there's not many causes of right heart failure that doesn't involve the left. So typically, if you have a right heart failure that's causing that delayed closure of your pulmonic valve, it would also be affecting the left heart, and so the S2 would still be together. And so I don't really like this one. I'm actually going to exit out right there. And we're just going to say atrial septal defect is our cause of fixed split, okay? You can write that down, take it to the bank, and cash it in. This is going to be good for a few points on step 1, okay? All right, great. Okay, right bundle branch block, this is some cardiology stuff that we don't really need to know for step 1. Okay, left bundle branch block, again, really kind of advanced stuff. Once we start doing step 2, you know, after you score 250 on your step 1, you're going to say, Aaron, I'm really happy with my score. I want you to help me tutor for step 2. And then we're going to talk about these bundle branch blocks. But till then, I don't really think it's worth your time to learn about them. Unless you're really interested in this, we can go over it, or I can kind of move on to the next thing. You want to see it? Okay, good. So right bundle branch block, what are bundle branches? So when we talk about electrical conduction through the heart, it's going to start at the SA node. Oh, it actually let me write that time. Okay, so it's going to start at our SA node. That's the node that is right by that tricuspid valve opening, and that is where all of our electrical impulses are going to start. It's going to travel from the SA node through the atria. It's going to cause that atrial kick through the atria, and eventually that signal is going to get to the AV node. Okay, now when it gets to the AV node, it's going to get delayed a little bit, and then it's going to be transmitted down through essentially the bundle branches. Okay, and so we have a bundle branch that goes to the right side of the heart, and we have a bundle branch that goes to the left side of the heart. And the goal of these bundle branches is to transmit all of that electrical conduction to the ventricles, okay? And so that is the goal of the bundle branches. That's what they are. Now, let's say our patient has some sort of heart attack, okay? And in this heart attack, it doesn't affect the whole heart, but it actually knocks out one of these bundle branches. So now, as that signal is being passed from the AV node to the ventricles, it gets delayed a little bit, okay? And since we're talking about right bundle branch, we're going to pretend I put that over here, okay? So say we have a heart attack, it affects that right bundle branch. What effect will that have on the heart? Well, if we can't send a signal from the AV node to the muscle of the right heart, we're going to have a delayed contraction of the right side of the heart. During systole, rather than having a nice contraction where all of the muscles contracting at once, the signal is going to take a long time to get to the muscle. It's going to reach some parts of the muscle before it reaches other parts. And essentially, we get just sort of this delayed conduction. Okay, and so what is that going to cause in terms of the sounds that we appreciate during physical exam? Well, when we normally listen to the heart sounds on physical exam, what we expect to hear is when our patients take a deep breath in, we get this physiological split where A2 comes before P2. That's what we're used to. We know what the reason is. It's because of all the blood in the lungs, yada, yada, yada. Okay, so now we have a situation where the muscle of the right side of the heart is not contracting at the right time it's supposed to. It's taking a lot longer. So now, instead of having our A2 and P2, I don't know if you can see my hands, but instead of having our A2 and P2 like this, now that pulmonary is getting even more delayed, more and more delayed because the conduction is just not getting there. It's taking a lot longer. And so now, instead of having a split on inspiration that looks nice and tight, now we have a wide split of A2 and P2, okay? And because when our patient is not taking a deep breath in, even when they're exhaling, you're still having that delayed conduction, that split is not going to go away, okay? And so what you're going to see is that you're going to have an S2 split that's always there. It just gets a little bit longer during inspiration, but it's always there, okay? And so that's basically all there is to it for right bundle branch blocks. In terms of identifying them on EKG, this is really getting into step 2 stuff, but I know you're hungry, so I'm going to tell you how to do it. Essentially, what you want to look for is something called bunny ears, okay? And so when you look on V1, talking about EKG leads, V1 through V6, I know you probably already know this, but V1 is sort of near the sternum, and so it's closer to the right side of the heart, versus V6 is all the way around the left side. So it's much closer to the left side of the heart, okay? And so in terms of looking at what a right bundle branch block would look like on your EKG, look at your V1 because it's close to the right heart, and look for bunny ears. Okay, and so what we see here, the technical name for it is RSR prime, but I call it bunny ears because to me it looks like a cute little bunny rabbit, and that's what we see. Okay, and then V6, this is close to our left heart, and it looks pretty normal. Maybe that T wave is a little higher than we like to see, but otherwise on V6, that's close to the left heart. Left heart's not really affected here. That's all fine. Okay, great. So that's our right bundle branch. Now, on our left bundle branch, it's the exact same thing in terms of the pathology. But now, since we're affecting the left side of the heart, we have to think, okay, so before we were saying that the left side of the heart, it's finishing its job quick, it's closing its valve quick. So that's why we see that split. We see A2 first before we see P2, because that aortic valve closes nice and fast while the pulmonic valve takes a little longer. Okay, so what's going to happen if we have a bundle branch block affecting the left side of the heart? Okay, Natalia, I want you to tell me, is it going to be a wider S2 split? Is it going to be no split? Or is it going to be the split changes where A2 comes after P2? Those are your options. I can repeat them. The third option. I like it. Yes. Great. So if the left side of the heart takes longer to finish its job, the sound is going to come later. Okay. So this is our paradoxical split. There's another way to get a paradoxical split that we're going to talk about later, but you know, for left bundle branch block, this is one way to get it. Okay, and just you know, what we just described is exactly what you would see in terms of your EKG. Now, instead of looking at our V1, we want to look at V6. That's our closest to the left side of the heart. And when we look at V6, we see, oh, look at that. It kind of looks like bunny ears. At least to me, that looks like bunny ears as well. And so, little tiny little bunny ears. And so here, that's where we're looking. We're looking on the left side of the heart, and we're looking for something a little bit similar. Okay. Now, as you've already gone through medical school, you've already, you know, learned this certain ways. Other people are going to explain it to you other ways. They're probably going to be better than mine. But at least this way is sort of what helped me in taking my exams. So yeah, that's why I pass it on to you. Okay. So the other way that we can hear a paradoxical split is in severe aortic stenosis. And so in the context of this class and really trying to succeed on step 1, I want you to memorize paradoxical split being caused by severe aortic stenosis. Okay? Why is it causing severe aortic stenosis? Well, we have a left side of our heart that's trying to pump blood through a tiny little hole. It's going to take longer, right? It all comes back to how long does it take to finish this job? If you have a tiny little hole to pump all this blood through, that's going to take longer, and that gives you a paradoxical split, okay? We're relating the physiology to the pathology, and because that's the way you got to learn it, okay? Great. So our third heart sound, we talked about this already. Our third heart sound is an indication that our heart or our bathtub is already full, and we're pouring more water or blood into it. Okay, so pathological. So just for normal, we talked about pregnancy. You know, women in pregnancy, especially in the 3rd trimester, have all this extra blood volume. Children and young adults, this can be completely normal. Okay, and so this is something to keep in mind: is that your third heart sound can be normal. Okay, that's different than when we talk about fourth heart sound. Fourth heart sound is always abnormal. Okay. But third heart sound can be normal. All right, something to definitely, a little star here, definitely keep that in mind, is that it can be normal. Great. So in terms of pathology, when is it abnormal? If you have any kind of dilation of your heart, increased blood within the chamber, we said CHF, you know, your dilated cardiomyopathy, that's what we look for. Okay. Great. Fourth heart sound, like we said, is always pathological. Hypertrophy of that left ventricle, some dilation, but essentially we have a stiff and non-compliant ventricle. All right, and this is just the sound of that atrial kick, just kicking that extra blood against that stiff wall causes that noise. Look at that size of that wall. Oh my God, that's thick. Okay. Great. So systole is just clinically how we describe it is just everything from S1 to S2. Diastole is everything from S2 to S1. In terms of murmurs, essentially it's just sort of turbulence and noise. Depending on when you hear that turbulence and noise is going to give you a huge clue about where the murmur is coming from. Okay, so systolic murmurs. They have to be, you know, if you hear at the aortic side and it's a systolic murmur, then you know it's a stenosis. Versus if you, you know, hear a systolic murmur at the mitral post, then that's a regurgitation, right? So where you place your stethoscope and when you hear the noise are going to be your 2 clues in determining what is the cause of the murmur, okay? So on your step 1 exam, what you're going to have is some questions that actually require you to interact. And so what it will look like is it'll be a box like this. Okay. It's not going to be black like that. Let me change that. Okay. It'll be a box like this. And inside of that box, you're going to have something that looks like a human chest. Okay. And on that chest, you're going to see 4 dots. And those dots are going to be representing all of the different posts. Okay. So The aortic post. Where is the aortic post, by the way? Where do you put your stethoscope to listen to the aortic valve? Excellent. Yep. Yep. Yeah. Parasternal. Yep. Absolutely. Everything is right. Yes. You haven't said a single wrong thing in this class, by the way. So definitely don't be afraid to, say what you think. You're 100% right. So the second intercostal space on the right side, parasternal, there's going to be a dot there. There's going to be one on the left, second intercostal space, parasternal. There's going to be one on the fourth intercostal space. There's going to be one on the fifth at the mid clavicular line. Okay, so you're going to have circles at all these different spots. That's going to be the question. And then you need to use the mouse and click each of those spots and use the headphones to listen. I am not joking. This is one of the questions on your test. Okay, you have to listen to each of those spots and determine what you think the murmur is. Okay. Yeah, I know. I think of all the questions on step one, those were the ones that I really spent the longest listening to. And it was something that I really felt confident about too. And so my advice in terms of attacking a question like that, the first thing, the big picture, is it systolic or is it diastolic? Okay. Because at the end of the day, you can always go to your answer choices, okay? And so if three of your answer choices are all diastolic murmurs, and then the last one is a systolic murmur, and then you listen and it's a systolic murmur, oh my God, click it and go to the next question. Don't waste your time, right? And so go big picture, is it systolic or diastolic? When you figure that part out, go to your answer choices and start eliminating answer choices that are not systolic murmurs, okay? If it's a systolic murmur and then the answer choice says aortic regurgitation, take it out, okay? Take out all of the non-systolic murmurs. Second thing you're going to do is you're just going to you're going to click the different spots and see where it's loudest, okay? You know very well what each spot is for. You know where the mitral valve is, where this is, where that is. You know where they all are. And so wherever it's loudest and making sure that it's, the systolic version or the diastolic version, just select that answer and move on to the next thing. Okay. We're not cardiologists. We are not, people that are really super trained in listening to these things. You really just kind of need to know the big picture and understand, I really felt like I was just trying to prove I was not stupid doing that question. I was like, do I know what these spots are? And do I know what a systolic murmur is? If I know those two things, I should be able to get the answer. And that's definitely going to be true for you, Natalia. Don't worry about that too much. I know it sounds scary, but I tell you about it so you don't get freaked out when you take the exam. The other thing is on the spreadsheet that I gave you for the free 120 questions, some of those questions are examples of that. Okay, so you'll be able to practice it before you actually take the real thing. Okay, wonderful. So let's keep it moving here. So all of our cardiac murmurs, our systolic murmurs would be our pulmonic stenosis, aortic stenosis, mitral regurgitation, tricuspid regurgitation. Anytime you have a valve that's supposed to be closed and it's open during systole, that's going to be one of those types of murmurs. Okay, it's going to be a regurgitation type. We can also hear our VSD and ASD during systole, mitral valve prolapse we would hear during systole, and hypertrophic cardiomyopathy. I believe we actually talk a little bit more about hypertrophic cardiomyopathy during our lecture on Wednesday, and so I won't take a long aside and talk about it now, although I really have to resist talking about it because I love talking about this particular disorder, and so does step one. But we'll talk about this more on Wednesday. Just know for now that it's a systolic murmur. For diastolic murmurs, we have our aortic regurg, pulmonic regurg, mitral stenosis, and tricuspid stenosis. If it's a continuous murmur, this would be something like a patent ductus arteriosus. The way PDAs are described is a machine-like murmur. I'm sure you've seen this before. When they describe a machine-like murmur, they usually describe it as radiating to the carotid arteries, radiating to the axilla, and it's continuous. It never stops. That would be a PDA. Pericardial friction rub. This is associated with our pericarditis. When we have an inflammation of the lining on the outside of the heart, that protective barrier, those layers of the barrier start to rub together, right? And so it actually is described as a crunching sound. I kid you not, if you look this up in any cardiology textbook, they are going to use a word that is spelled crunch, crunch. And it's just kind of like a constant crunching that goes with the heart sound. Crunch, 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 crunch. And that is just a sound of the layers of the pericardium rubbing together. Okay. And venous hum is a benign, normal, just the sound of blood flowing through the veins, essentially. Okay. And so this is sort of describing where we can see our cardiac murmurs in relation to the S1 and S2. So our early systolic aortic stenosis is something that's described as a crescendo decrescendo murmur. Why? When we talked about the cardiac cycle, what we said was as the blood starts to be pumped out of the ventricle, it's like lifting that weight, right? I was flexing for you, right? So when we grab that weight and we curl it, initially we have a lot more force and it starts to diminish towards the end of systole. And so when would a murmur be loudest? Obviously, when it's being pumped the hardest, whenever the blood is flowing the fastest. And so early systole is when aortic stenosis is going to be the worst. Hypertrophic cardiomyopathy, same thing. Mid-systolic mitral valve prolapse tends to be mid-systolic. Pan-systolic obviously means throughout systole. It doesn't really change in volume. And then for diastolic, I didn't write it here. I really should have. Aortic regurgitation is an early diastolic murmur. Okay, if you ever see these three words together, early diastolic murmur, please choose aortic regurgitation. That is like the buzzword clue. If you were the detective, this is the clue you need to solve the case. Early diastolic murmur is almost always aortic regurgitation. Okay, and so keep an eye out for that one because it's going to be important not just for step one. On step two, they're going to do the same thing to you. Okay, any questions on these murmurs so far? We're going to get into it a little bit more, but need to review? Okay. Which part of it? Sorry, what'd you say? Which is which? Yeah, I know. There's a lot of them. Right? And, it's one thing to talk about these murmurs, what they are. Okay, that's great. But then what we're going to do is we're going to talk about what makes the murmurs louder. We're going to talk about maneuvers, what happens when our patient squats, what happens when our patient starts standing up, what happens when our patient lays down. You have to not only know the murmur, but how that murmur is louder. And I highly recommend first aid. You have first aid, right? You need to get one? Okay, yeah. Order one as soon as you can, Amazon or whatever, because it's going to be helpful for doing this course as well. I think I use a lot of first aid in this course. I just blatantly steal their diagrams because they're so good. Okay, so any stenosis, this just means that the valve itself is narrow. Blood, as it goes through it, is making a lot of noise. Okay, so for an aortic stenosis, this is going to be heard in the aorta during systole. And this makes sense. Blood is trying to move from the ventricle into the aorta through a very narrow valve. It's going to be loud. That's a systolic murmur. Mitral stenosis is going to be heard during diastole. Okay, and so this is what we look for with mitral stenosis. Blood is trying to go from the left atrium into the left ventricle. It's going to make a lot of noise. Okay. So what, Natalia, what would be a cause of mitral stenosis that we should know? This is a tough one. I'm going to be honest. Mm-hmm. Oh, no, that's okay. So you're absolutely on the right track. I really like where your mind is at. So thinking about endocarditis. And endocarditis just an infection of the heart valves, a bacterial infection typically. And if that bacterial infection is not treated, you can have long-term mitral stenosis. The one that I really want you to know for step one, and the one that's going to be most common worldwide, is going to be chronic rheumatic fever. That's supposed to be a C. Chronic rheumatic fever. Okay. And so chronic rheumatic fever is a patient who had rheumatic fever when they were young. Sorry, this is a C. Okay. So a patient has rheumatic fever when they're young, and that rheumatic fever goes untreated. Now, what you're going to have is that at the sides of your mitral valve, they're going to become fused together. And so a patient that had rheumatic fever when they were a child, they immigrate to the U.S., and they come to see their cardiologist. The cardiologist hears this diastolic murmur at the mitral post, and that is going to be the mitral stenosis because of an infection that they had when they were young. Okay, so chronic rheumatic fever is going to be your most common cause of mitral stenosis. Okay, and one last caveat I will say about chronic rheumatic fever and acute rheumatic fever is that it's not the bacteria that cause the mitral stenosis or the mitral regurgitation. Okay, rheumatic fever is due to autoimmunity. Basically, there's proteins on the lining of our valves that look like the proteins that are on the outside of strep pyogenes. Okay, something called an M protein. And so what happens is our body mounts this response to this bacteria, right? A pharyngitis maybe. When they create these antibodies to this protein on the outside of the bacteria, the proteins on our heart valves look very similar. So when you talk about mitral regurg and mitral stenosis in the context of rheumatic fever, they are due to autoantibodies, not due to the bacterial infection itself. Okay? All right. And we'll talk about rheumatic fever on Wednesday a little bit more. All right, so great. Regurgitation insufficiency. So this is when we have a valve that's supposed to stay shut and it's not staying shut. All right, so a leaky valve here. The valves do not completely seal when the valve should be closed, allowing for backward flow of blood. Aortic regurgitation should be heard during diastole, right? Aortic valve should be closed. It's not. Now we have blood coming from the aorta into the left ventricle, from the mitral valve, from the left atrium into the left ventricle. All of that is happening at once during diastole, okay? And so we're creating a situation where the left ventricle is going to have to pump a lot more blood. For mitral regurgitation, now that mitral valve is not staying completely shut the way it should during systole. So blood is being pumped out into the aorta, and it's also being pumped backwards into the left atrium. So we're going to see things like left atrial dilation. We're going to see things like pulmonary edema because of all that blood that's going to be backed up in the pulmonary supply, giving us our crackles and everything else. Okay? So that's sort of the basics behind our terminology here, stenosis and regurgitation. Okay, any questions on this? Okay. Great. So aortic stenosis, I feel like I've really kind of killed this topic today, but there are a couple more things that we can talk about. First is going to be this ejection sound that we hear. Due to, thinking about aortic stenosis, we said the most common cause is just this calcification of the valve that happens normally as we age. Okay, so think about these valves that are just crusted in calcium. Okay, now whenever those valves try and open, and they're just, these are just like glazed donuts of calcium, it's going to make a noise as the valve opens. And so that gives us our ejection sound, okay? As this calcified valve opens, it's going to make a little bit of a noise as it opens, okay? So when you hear ejection sound in the context of aortic stenosis, don't get freaked out. It's just the sound of these crusty valves opening, okay? Left ventricular hypertrophy we expect due to that increased afterload. This is going to give us a concentric hypertrophy. What that means is that all of the walls get bigger, both the wall, the free wall on the outside, as well as the intraventricular septal wall. Basically, everything around the ventricle is going to get bigger. That's our concentric hypertrophy. All right, and we said aortic stenosis is associated with a paradoxical split of S2. This makes sense because the left side of the heart now is taking longer to do its job than the right side of the heart, so the A2 sound should be happening after the P2 sound, right? It's taking longer, so it's going to take longer for that valve to close, okay? Now, do you remember what the other cause of a paradoxical split of S2 was? It's either right bundle or left bundle. Those are your choices. Left bundle. Excellent. Good. So left bundle branch, we have less conduction to that left ventricle, and so it takes a little longer to close. Yada, yada, yada. You get it. Okay. So aortic stenosis. One thing that we can look at is, you remember this diagram we did earlier, right? Where we look at the pressures against time. And what we saw in a normal heart is that as soon as the aortic valve opens at about this point, that the pressure in the aorta and the pressure in the ventricle, they went together, right? And then after the aortic valve closed, that's the point that they separated. Now, in aortic stenosis, we have something very, very different. In aortic stenosis, we have the valve opens, great, but then the pressure continues to increase in the left ventricle, okay? However, the pressure inside the aorta only increases a little bit relative to the left ventricle, okay? And so the reason for this is because that left ventricle is having to generate a lot more pressure and a lot more force to get through that stenotic valve, okay? These diagrams are fair game for step 1. Anytime this pressure over time diagram is fair game for step 1, they will give these to you, and you have to kind of figure out what's going on. So, are you kind of comfortable with the way this looks? Would you like me to sort of explain it again? You understand it? Okay, yeah, I thought so. These diagrams, they'll give it to you and they'll say, what does this patient have, essentially? Or they'll give you aortic valve stenosis and then give you a bunch of these diagrams and be like, pick one. Which one would go with aortic valve stenosis? So, as you know, the pressure has to be much higher to overcome that stenotic valve. All right, and this is just showing the same thing. In a normal person, they go together from the time the aortic valve opens until the time it closes. That's when they finally separate. In a aortic valve stenosis, you see the pressure get much, much higher in the ventricle compared to the pressure in the aorta is not getting as high. Okay. Okay, great. Mitral valve stenosis. In mitral valve stenosis, we expect to hear a mid-diastolic murmur. And so that's great. Here, what we have is fused leaflets. And this is going to halt the mitral valve opening, causing an opening snap. Just like we talked about with our the ejection sound in our aortic stenosis. In mitral valve stenosis, that valve is going to pop open, okay? And so hearing that valve pop open gives us that opening snap, okay? And again, for the context of USMLE, first step 1, if you have a patient with mitral valve stenosis, that patient had rheumatic fever as a child. Guaranteed. That's how they can ask you about these things. They can give you a patient with mitral valve stenosis and say, what did this patient most likely have? Right? Sarcoidosis, some kind of weird, Raynaud's disease, a bunch of random stuff, and then an infection with pharyngitis infection as a child, right? Just kind of sitting there being non-assuming. That pharyngitis infection as a child is going to be your right answer because you need to assume that pharyngitis was strep pyogenes that induced a rheumatic fever that was not treated, and then that rheumatic fever went chronic, causing this mitral valve stenosis, okay? It's got to go A to B to C to D, and this is what you ultimately get after years and years and years of those autoimmune antibodies, okay? And so what can we see on the pressure time diagram here? What we see is that the pressure that's in the left atrium is just much higher than before. And that makes a lot of sense because with this mitral valve stenosis, blood is not able to move out of that left atrium and into the left ventricle. Okay. All right. And so here we can see a sort of a diagram showing two things. Number one is that we have this stenotic valve that gives this turbulent flow, which is what we can hear. And number two, look at the size of the left atrium is much larger. It's becoming dilated because of that increased pressure there. Okay. And then this diagram is similar to the diagram we saw in the last slide. Aortic regurgitation. Here we have a weak aortic valve, allowing blood to move backwards from the aorta and into the left ventricle. And that's what's being described here. And so here we get this early diastolic murmur. I told you how important this phrase is. Early diastolic murmur, 99% of the time they're talking about aortic regurg. Okay, if you see those three words together, please start looking for aortic regurg. Okay. Other things that we need to take note of. Number one, our aortic pressure overall is going to increase, and our ventricular pressure overall is going to increase. Look, on a normal person, we have 120 over 80 and 120 over 10. Here we have 160 over 60 and 160 over 20. Okay. So things that we see is, we see a higher pressure for systole, but then during diastole, we see a lower diastolic pressure. Okay. And so this is what we refer to as widened pulse pressure. Widened as in wide pulse pressure. Our systolic pressure is higher. Our diastolic pressure is lower. It's wider. Okay. Overall wider pulse pressure. In things like, hypertension, congestive heart failure, usually those numbers move together, right? If you have a hypertensive patient, they would typically be 160 over maybe 90. You wouldn't expect to see a hypertensive person be 160 over 60 unless they have this aortic regurgitation, giving you a decreased diastolic pressure. All righty. Great. Oh, and here we go with the slide. I've been doing this all day, kind of preempting my slides. So here, this widened pulse pressure, lower diastolic, elevated systolic. Okay. And so this is just sort of another one of the things that they can ask you about. Here is the diagram that you already described for me. I was very happy about that. You can see that the pressure in the aorta is dropping fairly rapidly. And so that gives you that lower diastolic pressure. And yeah, great. Now, mitral regurgitation. Here we have a weakened mitral valve. Typically, what you're looking for in terms of your patient history is someone who had a heart attack, myocardial infarction, that involved the left anterior descending artery or the left circumflex artery. Either way, you're looking for a history of heart attack, okay? Myocardial infarction. That myocardial infarction causes damage to the muscle that holds the leaflets closed, okay? There are muscles within your heart that project into the ventricle and have these long strings that go to the valves. I'm sure you've seen pictures of this. If you haven't seen the real thing, right, doing a cadaver lab, there's these strings that go from the chordae tendineae and attach to the valves. And then during systole, they kind of keep the valves shut. Okay, now, say you have a heart attack that affects those muscles that keep the valve shut. Okay, now, during systole, that valve's not going to stay shut, and you're going to have blood going backwards into the left atrium. Okay, so a myocardial infarction involving papillary muscle is the most common cause of mitral valve insufficiency, aka regurgitation. Same thing. Okay, all right, great. So here we're looking for a murmur that goes all through systole. It doesn't get louder and quieter like our aortic stenosis. It kind of stays the same level, okay? But you hear all through systole. And great. We can also have an S3 here, again, because we have all that extra blood, all that extra volume overload. On this diagram here, it's kind of like in the background, you can see what the murmur looks like. You see this kind of like blurry, furry looking thing in the background. So that is what the murmur actually looks like if you're listening to it. It's like a constant shh, 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 shh. It stays the same volume. Compared to a murmur that's like a aortic stenosis, should be shh, 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 shh. It gets louder and quieter, louder, quieter. This one actually just goes shh, shh, shh. Stays at the same volume the whole time. Okay, and if my beautiful heart noises does not convince you, don't worry, because when you do these questions, you're going to be able to put your stethoscope on these different spots and listen where it's the loudest. Okay, and so sort of two ways to skin a cat here. All right. Great. Okay, so, and here's just sort of our overview of all of our different murmurs and where you should see them. Okay, so we have some cases we can do. This is a asymptomatic 70-year-old man presents with a systolic murmur. As soon as you see systolic murmur, there's really two options for you. You can either have a mitral regurg or a narrow aortic valve, aortic stenosis. Okay, and so that at that point you kind of can start breaking your patient down, really taking a better listen to what's going on. Hearing the first sound is going to be key. First sound's still going to be heard in aortic stenosis. And then obviously you have that paradoxical split in severe aortic stenosis. Okay, great. Here we have a 55-year-old patient is presenting with exertional shortness of breath. We look at the blood pressure. We see a very high systolic, low diastolic. Do I need to say any more, or you have your diagnosis? Excellent. Yes, regurgitation. That wide impulse pressure, there's really nothing else that's going to do that for us. There's really nothing else that gives us a high systolic and low diastolic aside from aortic regurg. Great. And so that's going to be our diagnosis here. Aortic regurg is going to be that early diastolic murmur. We always hear it described that way. But if your left ventricle is now having to eject extra blood, now we're going to be kind of doing away with that laminar flow we talked about. We're going to have some disruption. There's going to be extra blood, so you may have some systolic component, but don't really focus in on that. Don't really worry about that. That's kind of like a caveat. That's not one of the primary things to worry about with this condition, okay? But it's there because it's true, but don't really, that's not a primary thing to memorize about this particular disorder. Here we have an asymptomatic three-year-old presenting with blood pressure 130/40, so a little bit elevated systolic, low diastolic. And here, this is actually going to be due to a patent ductus arteriosus. The murmur that we hear here is a continuous murmur, that machine-like murmur, and we are going to have increased size of our left ventricle with a decreased cardiac output. When we meet on Wednesday, we're going to talk about patent ductus arteriosus and what that looks like. Where is the connection that's abnormal? We're going to talk about all of our tetralogy of Fallot, truncus arteriosus, total abnormal venous artery return, whatever that thing's called. We're going to talk about all of those different conditions, right? A transposition. We're going to talk about all that stuff and what exactly is going on there. Okay, great. Now we have a 37-year-old Haitian man presenting with left atrial dilation. So here we can start to suspect mitral valve regurg insufficiency. Really, honestly, I don't like that. Personally, when I see someone who immigrated to the U.S. a little bit older, even with the left atrial dilation, I really think about stenosis. okay, I really think about stenosis because, someone who immigrated here may not have had access to proper healthcare in their home country. That depends, right, on their home country, but it's certainly a possibility, especially if they're giving you that as more information to work with. They may have had pharyngitis and not had it treated, okay, and so giving you that stenosis. But whatever, this says regurgitant insufficiency. And so here we have, it's going to be a systolic murmur, can cause S3 because of all that extra blood. And our patient is going to be easily fatigued because they're not having forward flow of blood, right? We're having blood that's flowing backwards into the left atrium rather than flowing forwards into the aorta. All right. And so now we have a Grenadian female, 28 years old, with severe shortness of breath, latent pregnancy, left atrial hypertrophy on ECG, and here we actually have a mitral stenosis. What we're looking for is that mid-diastolic murmur, and you hear the S2, and you may even hear a louder S1. Fluid in the lungs due to the backup of fluid ahead of that mitral stenotic valve. You can have some pulmonary edema. Okay. All right, great. So we have a asymptomatic 50-year-old with a history of ischemic heart disease, presents with a paradoxical S2 split. We can know that is left bundle branch block. We are going to look for some bunny ears on that V6 lead and have our diagnosis. 40-year-old female here, systolic murmur. We may think about anemia, because we talked about how anemia can lead to systolic murmur. As we decrease the viscosity of our blood, it's kind of sloshing around and whatnot. Okay, let's see. Okay, so this next part of the lecture is really getting into the physics of muscle contraction and how we're able to get activation and relaxation. Definitely important things that we need to know in here. I think less important than the beginning of the lecture. And so when we meet next time, we're actually not going to talk about this stuff. We're going to go straight into pathology because it's very important. And, each topic has something important in it. And so, I don't want to start pushing other things back and falling behind. So we're going to actually leave this be. You